Today, we are in nervous system disorders. And in order to get started, we're going to do a bit of review. You had 2 pre-quizzes, and you'll have 2 post-quizzes on Friday if you look at the syllabus. And the purpose of that is because there's a lot of material in nervous system disorders, and in order to get into the content of some of the highlights that I really want to focus on for the purposes of this class, I want to make sure that we slow roll a little of the review, because it might be a little bit of time since you guys have digested this. And I tend to see, from a review standpoint, the nervous system is not nearly as fresh as maybe some of the other systems. There's a lot to it. So if you recall, we've got basically 2 main cell types in neuronal tissue. We've got the neuron, and then secondarily we have these glial cells. And the neuron is excitable tissue, right? Action potential gets propagated. So the electrical signal travels down the neuron. So the neuron's the structure that has the sodium and potassium gated channels. If you guys remember, the potassium channel will open, and where does potassium go? In or out? Sodium. It rushes in because you're pumping it which direction? Out. And you pump how many sodiums out? 3, very good. And how many potassiums do you pump in? Oh, 2, very good. You guys are reading my hands. And so if you pump 3 out and you pump 2 in, right, you have more going out than coming in, positive-wise, so it creates what kind of charge inside of the cell? Slightly negative. Do you guys remember the resting membrane potential voltage? What was it? About minus 70 millivolts. Yes. Yeah, if you said 63, I would give it to you. That's close enough. Okay? So the neuron's the excitable tissue, but we have far more supporting cells. We have far more supporting cells. They outnumber the neurons about 10 to 1 in the central nervous system. So we've got glial cells. And glial cells are accessory cells. They're also referred to as neuroglial cells. They're the other cell type. In the central nervous system, we have 4 types that we've characterized: oligodendrocytes, astrocytes, microglial cells, and ependymal cells. And there are some pictures on the screen of each one of these. So this upper right cell is an oligodendrocyte. And these oligodendrocytes produce myelin in the central nervous system. There are myelin-producing glial cells. These oligodendrocytes, if their ability to produce myelin is compromised, then myelinated neurons don't have a wrapping. And the wrapping does what? What does the myelin do? It helps to speed up the action potential. It makes the electrical signal move faster. So the analogy that I used in 201 was the neural system is like electrical wires. And if you take a look at a neuron or a wire, there's some sort of insulation or casing around the wire. And that's the same thing with myelinated neurons. They propagate an electrical signal, just like wires. Astrocytes. Astrocytes, upper left. This is the principal cell responsible for repair in neural tissue. They help to transport nutrients and waste products to and from capillary networks. And because of this, they're critically important for metabolism. Astrocytes, the upper left. So you can see that there's a blood vessel in close proximity, and they're sort of the liaison for grabbing oxygenation and nutrients out of the blood vessel, primarily glucose in the case of the central nervous system. And then they deliver waste products back to the blood vessel. They're also very important in repair, and when you have trauma to the brain that we're going to get into, these astrocytes form a lot of the scar, or what's called a gliosis. So scar, or fibrosis in the brain, is called a gliosis. And you might see that post-stroke, okay, post-infarction, cerebral infarction, post-hemorrhage, post-trauma to the brain, and we'll get into all these sorts of things a little bit today and mostly on Wednesday. Okay? And some of the things that we're going to cover, we're going to look at hydrocephalus. We'll talk about multiple sclerosis, which targets these oligodendrocytes. We'll talk about traumatic brain injury. We'll talk about concussions and hematomas, contusions, right? How many athletes in the room? Okay, I mean, recreational or, like you've competed at a high level. I'm going to raise your hands. In a room like this, there's a lot of active people. How many people have had a concussion? Yeah, I saw a soccer player just raise her hand. Yep, I would agree with that. Football player. Okay. So we're going to talk about the brain and we're going to talk about injury on Wednesday. But having this background will help frame what that discussion or conversation is going to look like. Okay? All right, microglial cells. Microglial cells are like miniature macrophages in the central nervous system. They're the phagocytes of the central nervous system. This is the lower left, these microglial cells. They're seen in areas of infarct or hemorrhage. They're seen in areas of demyelination because there's an injury. If there's an injury, there's going to be like an inflammatory response, and the microglial cells are going to go there to kind of clean up the debris, and then the astrocytes are there to lay down new extracellular matrix, and that's where the gliosis comes in. Make sense? So I'm making a lot of parallels to the wound healing that we already talked about, so you guys can kind of see where these new characters play roles. Ependymal cells, the lower right, these line the ventricular system. Now, these are somewhat unique to the central nervous system. These ependymal cells line the ventricular system, and they give rise to the epithelial layer that's known as the choroid plexus. What's significant about the choroid plexus? What can you all tell me about the choroid plexus? Do you remember? Yes, sir. It absolutely does. Go with the gut feeling. That was good. So the choroid plexus is a network of vasculature that lines the walls of the lateral ventricles. And from that choroid plexus, you filter blood. And you filter blood to leave the red blood cells behind in large plasma proteins. And what comes through is a clear, odorless, colorless serum, which is cerebral spinal fluid, or CSF. Okay, we're going to talk about CSF here in a second. Bless you. But these are the cells that are really responsible for a process of filtration, because the CSF comes from the blood. Okay, it's filtered blood. It has a consistency very similar to blood plasma. Okay, if anybody's donated plasma. Right? If you've donated plasma, they pull whole blood out, they spin it, they take the supernatant, or the top portion, and then they reintroduce the cellular component back into you in the other arm. Right? So you're watching a movie and sipping on, not cocktails, but drinks, okay? That would be bad if it'd be way more popular if they served cocktails, but they wouldn't have a shortage of blood. I have a solution for you, but you probably won't take it. But I know how to get more people to donate, right? So you're drinking fluids and watching movies, and then they take the blood out here, they spin it down, and then they put the cellular elements back in the other side. All right, now in the peripheral nervous system. Again, this is all review. Is a lot of this familiar? Okay, so this is 201, maybe a couple of years ago, or at least a few semesters ago. We only have two accessory cells, or glial cells, in the peripheral nervous system. We've got our satellite cells, and we've got our Schwann cells. Satellite cells are similar to the oligodendrocytes. So the satellite cells in the periphery are what give rise to the myelination, just like the oligodendrocytes did in the central nervous system. And in some cases with multiple sclerosis, where I talked about how the oligodendrocytes are compromised, right? And you develop an hypersensitivity to either the myelin or the oligodendrocytes that are manufacturing the myelin in multiple sclerosis, and you demyelinate. So usually it happens first in the CNS, but it actually can move out into the periphery as well. And there it would affect the satellite cells. It usually starts in the CNS and goes peripheral. Yeah. Satellite cells. Satellite cells are very similar to astrocytes. So satellite cells are going to help with nutritional supplementation to the neuron itself. So these glial cells are accessory cells or supporting cells. They play like a secondary role to the main functioning neuron. All right, let's talk about the synapse. So we looked at, when we had a type 2 hypersensitivity a couple of lectures ago, we looked at the synapse, and I just want to draw your attention to what's happening here. So we've got, down at the bottom, we've got our postsynaptic membrane. Here we've got the neuron. Here's the nucleus. We've got the neuron, and we've got a gap, and this is our synaptic cleft. And if you recall, back in the neural system in 201, first semester A and P, we were sending this electrical action potential with our sodium-potassium gated channels. We were sending it down the presynaptic side, and then it triggers vesicular release or fusion of a vesicle that contains acetylcholine with the membrane, dumps its contents, and that's the little speckles in the cleft. And these little speckles or these little dots in the cleft right here are the acetylcholine that's actually crossing this chasm. They bind to the acetylcholine receptor, and we looked at a type 2 hypersensitivity disease, which was called what? When this was a neuromuscular junction. You guys remember that? We built antibodies that were blocking antibodies to the acetylcholine receptor just a couple of lectures ago. Do you guys remember what that disease was? Myasthenia gravis, right? Muscle weakness. And so normally it binds here, and then it opens up an action potential on the other side by triggering sodium channels to open on the postsynaptic membrane. So you could have neuron to neuron with a acetylcholine receptor sending the signal across, bless you. Or you can have neuron to muscle like we looked at myasthenia gravis, and that's referred to as a neuromuscular junction. And the area of interest is right here. So here's neuron 1, here's neuron 2. This little box right here is this blow up to the left, okay? So just reminding you where we are and what's going on, because when we start talking about sending signals, I want you guys to remember down in the weeds when you learned all this, some of you were probably thinking, I really don't know why I'm learning this. Why is this relevant? When we start looking at certain types of diseases here in a minute, and you start thinking about the intricacy of these electrical connections, and then in a stroke patient, you lose an entire region of the brain, right? And now those electrical signals don't fire. And the question is, will they come back? Well, typically in the brain, they won't. Typically. And we're going to talk here in a second about, okay, well, what depends on the stroke, if it's lethal, if it's non-lethal. It depends on where it is, if it's a sensory implication or if it's a motor function implication. And you've seen all these patients, right, in regular life. And those of you that are moving on into physical therapy, PA, physicians, nurses, right, you're going to be interacting with these patients. And so understanding neuronally what's going on, you're going to start putting together some of the stuff you already learned in the context of kind of the bigger picture. So what's cool about it is, you know, a lot of the, oh my gosh, why did I have to learn these channels and these gates and acetylcholine? Well, if you ever have a myasthenia gravis patient, it's nice for you to kind of understand conceptually what they're wrestling with. Or a multiple sclerosis patient, okay? Because in MS, right, here's our myelin sheath. It's kind of like this bolt. If you remember, you've got hopping of the electrical signal. And in if your instructor did a good job in 201, they would have showed you kind of the speed of conduction. There's videos. You can look at videos online that show the speed of conduction between a myelinated and non-myelinated axon. And it's not that it hops this way over. It hops internal, right? Because there's a myelinated sheath there, there's no sodium-potassium gates in that region because there's a fat layer. And so it actually propagates sub-fat inside and then pops its head up. It's kind of like swimming the length of the pool, and then you pop up for air, and then you go back under. But imagine if you could hold your breath for almost the entire time, and you had to pop up once, because that's where there was a gap in myelin. And every time you pop up for a breath of air, that's where sodium channel actually has to move. Okay, so the function of myelin, okay, the function of myelin is important in the context of propagating this action potential. So if you have a multiple sclerosis patient, which if you're in those disciplines in the future, you will. You absolutely will. Okay, now you'll understand kind of what we're talking about. Okay, there was a question here. Did you already forget it? Sorry. Okay, I apologize. So let's correct. So satellite cells are going to act like astrocytes. Schwann cells are going to act like oligodendrocytes. I might have misstated that. Thank you. So let's repeat that. Satellite cells act like astrocytes, and Schwann cells act like oligodendrocytes. Sorry. Sometimes my brain goes faster than my mouth, or the other way around. Then, in 201 in the past, we've looked at carving out different categories of the nervous system. So we've got the CNS and the PNS, central nervous system and the peripheral nervous system. And if you recall, the central nervous system is made up of the brain and the spinal cord, and the peripheral nervous system, which is much more comprehensive around the body, is made up of mostly sensory or motor. And then under sensory and motor, we've got either visceral or somatic, visceral referring to kind of the thoracic and abdominal areas. And then, of course, we further divide it into sympathetic and parasympathetic. Now, remind us, what is controlling sympathetic activity? Or what are the outcomes of sympathetic activity? What dominates? Fight or flight. So give me some examples. Heart rate goes up. A sympathetic stimulation, heart rate goes up. Breathing goes up. Okay? What's that? Eyes are dilating in order to bring in more light. What else? Blood vessels will constrict to non-essential areas, like you'll shunt blood away from the gut and you'll move it to the periphery into your muscle, exercising muscles. Absolutely. Now, parasympathetic, in contrast. Rest and digest. So give me some physiology examples. So you'll dilate vessels in the core and in the abdomen, in the GI tract, in order to facilitate digestion. Okay, you're going to shunt it away from the muscles, skeletal muscle, and heart rate will drop, breathing will decrease. I mean, you're basically trying to go to sleep after the meal. Okay? Very good. All right. So at this point, I want to talk about the CNS most specifically, although we'll get into some of the peripheral nervous system. But most of what we're going to talk about in nervous system disorders are disorders that happen with the central nervous system. But I wanted to put it in the context. It's not that there aren't peripheral nervous system problems, okay? Bless you. But a vast majority of what we deal with happens to be the CNS, okay? Especially with the things that are coming that we talked about. Hydrocephalus or cerebral edema, brain tumors. We'll talk about next week's cancer. So we'll talk a little bit about brain tumors to this week, and then we'll finish it up next week in our cancer section. The CNS is really kind of carved out into basically three axes, right? The central nervous system. So you've got a top to bottom orientation. Top to bottom. You have a left to right orientation, and then you have a back to front, or a caudal to cranial, right? Or caudal is down and cranial is top, sorry. Posterior to anterior, okay? So 3 orientations, top to bottom, left to right, back to front. Let me explain. Is this foreign to you guys? Okay. So some of you are shaking your head yes, some of you are shaking your head no. So back to front. So sensory tends to be towards the back, and motor function tends to be towards the front. So if you think about the central sulcus, if you're posterior to that, you're sensory, and if you're anterior to that or towards the front, you're motor. You guys remember that? The homunculus? So if you look at areas of the brain that are towards the posterior aspect, like the occipital lobe is vision, which is sensory. And then as you move towards the front, it's motor. And like the frontal lobe is higher function, but higher motor function as well. That's where you're going to think about coordinated activities, or what do I do next, right? If you're an athlete, right, I mean, the coaches always just say, if you're in the field, where's the play? When the ball's hit, how many outs and where's the play? You're using your frontal cortex, right? When you're thinking, if you're a softball player or you're a baseball player, and let's say you're an infielder and there's a runner on first and there's 1 out and you get the ball, where's the play? Tell me, where's the play? Second, thank you, okay. All right, plays at 2, right? And some of your infielders will chatter, plays at 2, plays at 2. You're using the front part of your brain, okay? Now let's go bottom to top. Higher order functions that you think about, like the plays at second or the plays at 2, or let's get to, right? If there's 1 out and there's a player at first, plays at 2, but then throw it back to first to get the runner at first, right? Now you're out of the inning. You guys remember this? Okay. So higher order function, where you're thinking through things, like, okay, so what's Keller going to ask next exam? Are there a bunch of softball questions on the next exam? So you're using higher order thinking, which is towards the top. Autonomic function, none of you are thinking like right, breathe, heart rate, heartbeat, breathe, right? That's all down here at the level of the brainstem. So autonomic functions happen down at the brainstem, while up top, higher order thinking happens. Last one, and I'll explain why this is important. Clinically, not just for the exam. Left to right. Left to right. There are certain centers. We're looking at the left side of the brain over here, and we're looking here at Broca's area, and then back here we're looking at Wernicke's. You guys remember these two? So Wernicke's area is sensory for speech because it's towards the posterior aspect. It's on the left hemisphere. And then Broca's area is motor function on the left hemisphere, but towards the front. So now you have understanding speech, and you have forming speech. You guys understand the difference? Okay? So if your A&P professor didn't lay it out that way, I apologize, because that's really one of the best ways to study the brain. Here's the reason it makes sense. If you have a patient that had a stroke and presents, and they are having trouble explaining to you what's happened to them, okay? They're in the ER, they're checking in, and they're frustrated because they know the answer and they understand what you're asking just fine. But they have to start over again. They explain it and then they have to start over again, okay? Where is the lesion that you might be worried about? It's in the left front hemisphere, okay? Max. Oh, yeah, because, so the question is, if they're having trouble with speech and they may have a mini stroke or a transient ischemic attack, we'll talk about these, can they usually scribe it out? Yeah, a lot of times they can write it just fine, okay? Because that's motor function, and but it potentially is on a different part of the brain, right? So motor function, if let's say they're right-handed, so motor would be here on the left side for the right hand, but it's area away. Now, if it's a large stroke, right, and I don't mean this disrespectfully, but their right hand could be like this, and they might have trouble forming speech. Does that make sense? And you've seen some patients that will have kind of a limp, and so that means that that stroke hit this part of the motor cortex, and that's the area where you have the gliosis. That's the traumatic lesion. Okay? Yeah.
You said the Wernicke's broken there were both on the right side.
Left.
Left.
Yeah, correct. Because that's where those centers are located.
So the first time I heard about this, I heard that Broca's was on the left side and Wernicke's is on the right side. And that's why when people have strokes, they're less likely to lose both of those areas. But why? But if they're on the same side, why isn't it more common that they just lose both areas? Don't strokes just attack one side of the brain?
No, not necessarily. So, couple things, couple questions. So one is, these centers are shown here correctly on the left hemisphere, okay? There's no prediction for how strokes are going to occur, number two. We could probably look up statistics on stroke occurrences, but there is just as many people that have localized strokes that survive, that have, quality of life is compromised, but they can get through, as there are patients that have lethal strokes that don't actually survive. So it just depends on how broad the stroke is. So let me ask you this question, folks. We're talking about survival strokes. What if the stroke is down here? Yeah, there's no surviving that for the most part. Okay? Something in the brainstem that's automatic, heart rate stops or breathing stops. And so it just depends on where the blood flow is restricted or what caused the stroke or the trauma. Right? It could be a car accident, it could be traumatic injury to the brain, and we'll talk about all these things. It could be vascular problems of the carotids that go up, and depending upon where the lesion is, right? They come up from the common carotid, and then it bifurcates into internal and external, right? And then it perfuses that circle of Willis, and then it goes out from there into a microvascular tree, and depending upon where the blockage occurs in the microvasculature, that's the region of the brain that's going to lose blood flow. You with me? If it's endovascular problems or vasculature problems. Okay, these are great questions. All review, but now we're starting to layer into it some of the why I'm reviewing it, because this is actually very relevant for you guys to think through. And maybe it puts in context a little of the old material that you learned into a new light of why you might be more interested in caring about it. Okay. All right, let's not forget our meninges and our ventricles. Right, again, review. We have 3 meningeal layers that cover the brain tissue. Right, you probably did a dissection of a sheep brain in 201 lab. And either your brain came out nice and pristine because the meningeal layers were already removed, or there was kind of like this yucky film on top, right? And that yucky film would be these meningeal layers. Now, if we look at the ventricles, so we have 2 lateral ventricles, a third, and then a fourth. So they just don't call them 1 and 2. They call them lateral because they're right next to each other. They're like twinsies. And then the third is inferior, and then the fourth is inferior and slightly anterior to the third. We've got this solution or this fluid that we've talked about that is manufactured from the choroid plexus within our lateral ventricles. Lining the choroid plexus is the ependymal cells, and they filter the blood, and they make cerebral spinal fluid, which actually starts in the lateral ventricle. It moves to the third ventricle, then the fourth ventricle, down the central canal, and then up around the brain through the subarachnoid space. So in essence, the brain is floating in this central cerebral spinal fluid. Okay? And you manufacture it on a daily basis. So about a half a liter is what you make. About a half a liter, 500 mils. You filter that, you produce it, and you absorb the same amount. If you make 500, you absorb 500. Where does it go? Well, it comes back into the venous circulation within the meningeal system. Okay? So it ends up into a villus, which dumps right into the venous circulation. This is going to be important, so we'll come back to this in a second. And let's not forget the spinal cord. We've got, different slices as we're working our way inferior down from the thalamus all the way down through the spinal cord. And I'm going to highlight a couple of different areas that are interesting because trauma or injury to these can be altering in certain clinical circumstances. So the Pons, this is relaying information from the cerebrum to the cerebellum, and it's associated with sleep, hearing, equilibrium, taste, eye movements, facial expressions, sensation, respiration, swallowing, bladder control, and posture. So a lesion, maybe it's an infarct, maybe it's a tumor, okay? Maybe it's traumatic injury at the level of the brainstem or the level of the pons, and that whole list of things would be impacted, okay? The cerebellum. The cerebellum is what we refer to anatomically as the little brain. It has right and left hemispheres, just like our cerebrum. They're connected by a vermis, and it's got folds and grooves and hills, okay, or folds or folia called gyri and grooves called sulci. And it is instrumental in coordinating muscles activity or a series of muscles that are working together in contraction. It also has over 50% of the neurons in the brain, even though it's less than 10% of the volume. Many of you have seen this slice where you look through in a cross-sectional view and you can see the arbor vitae, right, or the tree of life. So that's white matter that is tracking within the cerebellum, giving it sort of this cauliflower-like appearance. This structure sits just above the fourth ventricle. The next one is the medulla oblongata, and this will be the last one that we'll kind of cover specifically in our little review. But this is really an extension of the spinal cord. It's the most inferior portion. It serves much of the autonomic functions like cardiac centers and controlling intrinsic heartbeat or force of the heartbeat. It has reflex centers for coughing, sneezing, gagging, swallowing, vomiting, salivation, sweating, movements of the tongue and the head. The medulla oblongata is what keeps you, kind of awake in class, hopefully. Allows for arousal. And what's interesting is in an old form of capital punishment, death by hanging, it wasn't asphyxiation that would actually terminate the sentenced individual. It was actually snapping the brainstem at the medulla oblongata. So actually, their heart stops. Okay, and if you snap the spinal cord there, just above it, right at the level of the pons, you've got your centers for what? Respiration. And so if you snap here, you turn off activity for heartbeat and respiration. Now, more recently, this is where snipers are trained to shoot, is at the base of the skull to try to pierce the medulla oblongata and actually one shot, one kill. So when we look at the central nervous system, we look at the autonomic nervous system. I'm showing this last picture because I want you guys to see that it's integrated, right? I say this a lot, that we kind of arbitrarily call out these labels and these buckets that we put all of this information in because it's easier for us to create lecture slides. It's easier for us to put a whole class into three different units, right, and put it into different categories. But they're extremely integrated throughout the entire body, right? So you've got the sympathetic division that's portrayed on the left side of the slide and the parasympathetic division that's portrayed on the right side of the slide. And many of these organs and tissues have dual innervation. They're dually innervated, meaning they have things that will stimulate them sympathetically, and they'll have things that stimulate them parasympathetically. Okay? And just remember, like, so for example, with the heart, so the intrinsic heart rate of the heart is about 100 to 105 beats a minute. So if you excise a heart ex vivo and you keep it alive, okay, and you haven't done anything, it'll beat at about 100 to 105 beats a minute. Now, in you and I, resting heart rate is much lower than that. Resting heart rate of an individual is where? Well below 100. Okay, depending upon fitness level of the individual, right? You might be 60 to 80. There are patients, there are elite athletes that at rest, maybe laying down supine, right? Like laying down right before they fall asleep, they're in the 40s or 30s. They're still awake, okay? So if intrinsically it beats at 105 or 100 beats a minute, obviously at rest right now, your parasympathetic innervation is telling it what? To slow down. So now the fire alarm goes off and our heart rate's going to race. The first thing that happens is just by turning off parasympathetic flow, you go from your 60 to 100 just like that by removing the brake. And then the sympathetic innervation will take it from 100 on up. Make sense? So it's pretty elegant how the body is designed in this way to have all of these different control mechanisms. But I just want you to be able to appreciate one doesn't regulate one organ and the other regulates another. Okay, most organs are dually innervated. Okay, let's go back to the meninges. That's our summary. That's kind of our review. Now we're going to start applying it in very specific applications for the rest of the lecture. Questions? Okay, so we spent about, a good half hour to 35 minutes doing review. But I think it'll serve us well for today and Wednesday. So let's look back at the meningeal layers. And I want to characterize two different disease states, but this is kind of the area that we're focused on. At least for one of them. We're going to compare and contrast. So I want to compare and contrast cerebral edema to hydrocephalus. And you probably already learned about hydrocephalus, because it's very common to learn about hydrocephalus in 201. Okay? So cerebral edema is an accumulation of fluid in the parenchymal tissue of the brain. Now, I've been accused of using words that maybe people don't understand. So that happens on the exam. I want you to ask Richard or I. Some of you did a great job of that. Okay? I don't understand this word. I'll give you a synonym. I'll substitute another word for it. Parenchymal tissue just means functional nervous tissue. Functional nervous tissue. So cerebral edema is an accumulation of fluid in the brain tissue itself. Why in the world do you think there would be fluid there? What would cause fluid to accumulate in the tissue? Injury, damage, swelling, inflammation, right? Remember the whole transudate, exudate thing? So if we're talking about the brain itself, some damage or injury happens in the brain, we're worried about swelling. Okay? Now here's one of the complicating factors with brain injury. Is there is this confined cranial cap that encompasses the entire brain. And so if you have swelling, is there any, unlike your ankle, when your ankle swells up and you're like, oh my gosh, it feels so uncomfortable to put my shoe on. You guys have been there, right? You can't take off your cranial cap. Okay, you can't wear like a house slipper or like half of a cranial cap around the grocery store because it's uncomfortable. So that's why it's such a problem. So if you have swelling in the brain, we worry about this. Could that swelling in the brain, if in certain locations, put pressure on critical centers? Absolutely. Okay. Could it be so aggressive that it kills a patient? Yes, absolutely. Okay. So cerebral edema is this picture on the lower bottom, lower right. Cerebral edema, if you look at this cross-sectional view, you'll see that the midline shift of the brain, so this is the patient's right, this is the patient's left. Do you see the midline is pushed this way? So it's pushed to the right side, right here. Do you see this? Here are our lateral ventricles. So this side is swollen, causing the midline of the brain to push over. You guys with me? So there's some inflammation or swelling that's happening on the left hemisphere that's causing the brain to shift to the right. Now, hydrocephalus is shown in the upper right picture. Hydrocephalus is a problem with cerebral spinal fluid production or drainage. And so this is a picture from an anterior view, right, of a coronal section, and you're looking at the lateral ventricles that are completely blown out because there's so much CSF being produced, or there's CSF being produced and it doesn't have any drainage that's taking place. That's hydrocephalus, an increase in cerebral spinal fluid presence, either too much production and or not enough drainage. Parenchymal tissue is just functional brain tissue. So we've got two causes for cerebral edema that I want to talk about. Two causes. One is cytotoxic, and the other one is vasogenic. So cytotoxic is there's an increase in fluid in the brain that's secondary to injury, right? Neuronal tissue is injured, glial tissue is injured, or endothelial tissue is injured. And you've got generalized hypoxia or ischemia, and you might have a toxin involved, okay, or a bacteria. That's cytotoxic. Vasogenic is where the blood-brain barrier is disrupted and the fluid leaks in. Vasogenic is referring to the vasculature, in other words. A lot of times the inflammation with vasogenic edema is because there's a tumor. There's a lesion. From what? Well, usually, so both of these, there'll be pressure, but now the question is what's causing the pressure. So you're right. So in cytotoxic, the pressure is injury, and now there's inflammation. And with vasogenic, the problem is there's either a tumor that's putting pressure there, or the vasculature flow is actually compromised. So what happens to tissues that have ischemic or hypoxic injury? Okay, an infarct, there's tissue trauma. If there's tissue trauma and there's an infarct, what cells, we're in the central nervous system, what cells are going to respond? Okay, so astrocytes would come at the end, okay, laying down new matrix for a scar, but before that, what would you have? Microglial cells, very good. So you get your little inflammatory cells that come in, right? They're being recruited by an inflammatory event because you have injury. And then the glial cells come in at the very end when the inflammation wears off, and they lay down a new matrix. Yeah, so it's a collagen-like matrix, just like what happens in the skin. It's a scar. So it's not regeneration. So when a patient post-stroke has scarring in the brain, you filled in the gap, but you have not returned neuronal organization or activity. And so post-stroke patients oftentimes will have some sort of compromised function if they survive the stroke. So the question is, doesn't brain function tend to move? So stroke patients that survive, okay, they'll go to physical therapy. So physical therapy, future physical therapists, what are you doing? Are you growing new central nervous system neurons in the patients? No. What's probably happening is you're figuring out alternative electrical signaling pathways, and you're rerouting some of those signals. You're creating new routes. And so the neural system, the central nervous system, is still very plastic, and you can kind of reroute the signal. It's kind of like, when you ask for directions on your phone, and then you can't figure out which way is north, and you just start driving, and then she nicely says, or he nicely says, depending upon what your audio is set at, at your earliest convenience, make a U-turn, right? Some of you have some app that's, like street language to tell you to turn around, but it reprograms. Okay, so that's what's happening in those patients. Well, I mean, it can be pretty full. It just depends on the extent of the injury. Okay. Let's look at this picture. So, in this picture, this is a real patient. You're looking top down at the patient. Eyes are towards the ceiling. Back of the head is towards the floor. Patient's right side, patient's left side. Give me some observations. What do you see? Okay, inflammation of the left side. A couple other people, raise your hands. Front.
Ventricle on the right side is that black ventricle looks like it's full of something, full of fluid.
So it's not very interesting, I would say. I mean, it is the ventricle, but I wouldn't worry too much about it. Yeah. Pressure on the skull. There's absolutely pressure on the skull. What gives you sense that there's pressure on the skull? There's a midline shift. You guys see this? Midline shift, this time this direction. You guys with me? Could you trace the abnormal tissue based upon density? So do you see the tracings that I'm going right here? This is all cerebral edema on the left side. This is a normal hemisphere, except that it's being pressured by the left hemisphere, and this is all cerebral edema. This is because of a tumor that's in this patient. Okay? This was my mom. This is my mom's MRI. Kind of interesting, huh? So this would be what type of cerebral edema? Tumor. Vasogenic. Absolutely vasogenic. Okay. This picture is not mom. Okay? This is not mom. This is from a textbook. So cerebral edema, what I want you to notice is this is at autopsy. They've cut away the cranial cap. And what I want you to see is how flat the surface of the brain is, because that tissue has been pressed up against the skull cap. A lot of pressure in cerebral edema. What do I mean by flat? Well, do you see right here that it's not, these gyri are usually kind of like humps. And right here you can kind of see it looks like it's been squished down. Okay, cerebral edema. So let's contrast these cases where it's a tumor, okay, or vasogenic or cytotoxic, where you're getting swelling of the brain tissue. Let's contrast it with hydrocephalus. And I want to characterize a case. This case is kind of tough to talk about. This is in India, and this took place a number of years back, kind of in the early 2010s, like 2013. And this is a girl named Runa Begum. And she's 18 months old, and you can see something's going on with her head, right? She has hydrocephalus. So there is not appropriate draining of the cerebral spinal fluid into the arachnoid villus that dumps into the venous circulation. And so what you have is you've got a buildup in that situation going on. Okay? So in little Runa, we had the story begin kind of in 2013. Her head grew to about 94 centimeters in diameter, which is about triple the size of a normal baby's head. Her father and mother couldn't afford to treat her, and the treatment in our country is actually quite simple. It's a little shunt that's put into the arachnoid villus that drains the cerebral spinal fluid back into the venous circulation. Obviously, it's a fairly invasive surgery, but it has a high success rate, and you completely avoid the swelling of the lateral ventricles. Now, why does Runa's head, why is it enlarged? What's that? She still has fontanelles, or the soft spots, right? So those are the parts in the head where the cranial skull bones haven't necessarily fused yet, and there's cartilage. And so it allows for the head to grow as the brain enlarges during pediatric growth. But in this young little girl, and her dad was a bricklayer earning less than $3 a day. So they took care of her as best they could. And there were 2 Norwegian students that were on tour, and they were doing a school project in developing countries. We used to call them third world countries, but developing countries. And they came across this family in this city, and they went ahead and photo documented and created a crowdfunding website. The whole idea was to raise $1,600 US to fund the shunt surgery. It's about a $1,600 surgery. And in 2 months, they raised double that amount. And by August of that year, they started in December, by August of that next year, they had over 60,000 US. So she had 5 shunting surgeries, probably because they didn't catch it early enough, okay, over the course of time. This is how big her head got. So these are like real pictures. This isn't necessarily fictitious or photo altered. This is her when she's leaving the hospital after her last surgery. And then this is her looking much, much better, right? This is by the following Christmas. And her head was down to 58 at Christmas time, and a couple months after that, it was down another 10 centimeters. So this kind of stuff really does happen in the world today. And so many of you, they're going to move on to be physicians and nurses. There's a lot of opportunities to treat patients even outside of our country that are wrestling with things that our kids never see, because our medical care, contrary to what the media might try to portray, is actually quite good in this country. Okay. Questions over hydrocephalus versus cerebral edema. So very different issues associated with central nervous system parenchymal tissue problems. Max. Venous circulation. Good question. So the question is, why would you put a shunt in and drain the cerebral spinal fluid back into the venous circulation? Why not just let it like dribble out the back or something? Or yeah, that's easier. Yeah. Yeah. It's a simple answer. So with her, you can see that it got very aggressive, and so they probably had to do shunting surgeries to handle all of the excessive fluid, because in pediatric cases in the U.S., there's not that volume of fluid to deal with. So they probably had to go with either larger and larger shunts, or they would just get overwhelmed with the volume of fluid, and they'd have to replace it. To answer your first question is, there's a risk of infection if you have something hanging out of the body. So you wouldn't want to just drain it. Not only does it look funny, hey, you're leaking off the back of your head, but there's a risk for infection, and that would be an infection into the central nervous system. That would be lethal. So they keep it inside. It's all sterile, and there's no opportunity for infection, and the patient has a better chance of surviving. Okay. In the back and then up front. It does. If it's in this case, unfortunately, that's one of the biggest problems. Is cerebral development was compromised in that little girl, quite dramatically. In the U.S., usually they'll catch it pretty quick, so they won't hit some of those early pediatric milestones. They may not be rooting quite as well. They might have problems with vision or with hearing. They might fail like 2 hearing tests. I mean, we have 4 kids. I remember our third daughter failed her first hearing test, and my wife and I were just so stressed out. As a parent, those are always like the panics that you have. So there are developmental cues, and that's when those of you that do have kids, or those of you that are going to have kids, that's why those pediatric milestones are in place. Is they're trying to gauge, is normal development happening, and if it's not, what's going on? Should we investigate? So they catch it pretty early in the United States. We have actually rather good health care where we do catch it pretty good. Okay, I mean, you guys are seeing that too right now, of how great our healthcare is in comparison to the rest of the world, just with this coronavirus thing that's going on. And it's just a matter of time, most likely, that we'll have more and more cases show up here in the U.S. But we rare or very unlikely that it's going to get to the level that you're seeing in some of these other countries. Okay. Question? I don't know. I don't know about her vision. Oh, like in the early, like in this one picture when I was reading, her eyes are actually open. You just really can't tell. Yeah, I imagine it was like swollen shut, but I didn't read anything specifically about vision being compromised. To the point in the back, unfortunately, after the surgeries and everything went down, she was definitely delayed from a developmental standpoint. Yeah. Yep. Hydrocephalus? I haven't seen anything where there's a genetic link on hydrocephalus. I think it's probably just, one of those things where developmentally in some, embryos, the cerebral spinal drainage architecture doesn't fully connect up. But I haven't seen anything in the literature to suggest that there's a genetic component. Yeah, the swelling is even on the edema for hydrocephalus patients. Yeah, it's not draining anywhere. And so you get global swelling in the ventricular system and in the subarachnoid space. Yeah. Okay. Great questions. Little bit of time to cover one or two other topics just to introduce, and then we'll hit the pause button. So one of the things that we worried about when we talk about cerebral edema, going back to the cerebral edema, pivoting away from hydrocephalus, but with cerebral edemas, we worry about herniations that take place within the brain. And this is due to an increase in intracranial pressure. And so you can appreciate in runa and in patients that have, or cancer patients, that there's the opportunity for pressure to be so great that you create either an infarct or you create different types of hernias, okay, where you've got brain tissue that's kind of bulging out into another region because it's being pressured, like you see with the midline shift in these particular patients. And so an infarct, I think, is pretty obvious. I mean, we've talked about infarcts quite a bit. That's just where you've got tissue that's being compromised and blood's not flowing into it, and so it dies. So that means that blood may not flow into it because maybe there's so much pressure that it's putting pressure on the blood vessel that's bringing fluid in. Make sense? Or the infarct could be because the vessel itself is diseased and it shuts off blood flow. Okay. But in this case, we're talking about increase in intracranial pressure. Our hernia types are labeled by the different locations that they're found. So the subfalcine is the most common. You can see here kind of at the upper portion hemispherically in between where the central sulcus is located. Subfalcine, most common. A uncinate is more of a temporal lobe that's being affected. And then the tonsillar is down here towards the brainstem. It actually has nothing to do with the tonsils. It's just kind of in the region of the tonsils, like at the level of the neck or the throat. But it's really impinging on the brainstem. And then the last one that I'm going to talk about, which is really more of a hemorrhage, but it's usually classified within this category of a hernia or a brain herniation, is a Durrett hemorrhage. So in a Durrett hemorrhage, this was described where the brain is actually deflecting downwards and you get bleeding that occurs in the pons and the midbrain. And that's a picture of Henry Durrett's Durrett hemorrhage of the pons or the midbrain. So you're actually having active bleeding that's taking place in this particular type of a brain herniation. Okay, so active bleed. So other types of diseases that we worry about, now we're on the vascular side, and we're in the vessel itself. And we're talking about cerebral vascular disease. Cerebral vascular disease, otherwise referred to as a stroke, is where there's a problem with the blood vessel. There's usually atherosclerosis. There's a compromised lumen, so the blood flow into the vessel is reduced, and therefore oxygenation to the tissue is compromised. So in cerebral vascular disease, or in other words, stroke, if we're looking at the end of the blood vessel, let's say this is the vessel here, we might see that this is kind of a normal lumen. And then if we look at a vessel that has some sort of disease, you might actually narrow that lumen, okay, down. And that's because in this area, there's all of this junk that's actually grown in. And we're going to talk a little bit more about what this atheroma or lesion is made up of at the very end of the semester. But this lesion reduces it, so you might say if this is a normal cross-sectional view of a cerebral vessel, this one is reduced, say, down to 40%. So it has a 60% blockage. So if you hear either neurovascular surgeons or you hear cardiothoracic surgeons talking about the patency of the vessels or the main vessels that they're worried about, they'll actually do angiograms, and we'll talk about this a little bit more on Wednesday. I'm just kind of setting the stage for that, where they actually inject a radiopaque dye into the bloodstream, and they, under X-ray, they'll see the radiopaque dye fill the vessels, and they can determine how reduced blood flow is based upon the thickness of the injection, okay, that's supposed to go through the lumen. So there's really three processes here that could take place when you've got that situation that I've drawn on the screen. So number one is you might have what's called a thrombotic occlusion, where this actually blood flow clots off and blocks it. You could have an embolic occlusion where something gets trapped and stuck in there. Or last, you could have a hemorrhage or a rupture, where this area is actually weak and you could actually blow this out because the inside of this is pressurized. And if you actually have a leak or a hemorrhage, then you actually have blood that's leaking out, and that would be in the brain considered a bleed. Okay? And that last one is what we have happening in a Durrett hemorrhage that we looked at on the previous screen. This is where that hemorrhage is. That's an example of what we're talking about on this particular screen, where this is actually compromised. Now, on Wednesday, we'll look at other types of brain bleeds that come from trauma, not necessarily from atherosclerotic disease, because that's usually happening in our older population, right? In our older population, when the blood vessels are compromised, atherosclerosis happens ubiquitously throughout the whole body. It doesn't just target certain vessels. But because these vessels in the head and the vessels that perfuse the heart are small in diameter, when you have a little bit of reduction, it makes a big deal, right? It's a small tube to begin with. If half of it gets blocked, blood flow is reduced. Okay? We'll talk about on Wednesday, how do you have vessel rupture in cases of brain trauma, like in a car accident or in head trauma. All right? See you guys on Wednesday.